So it's my great honor to introduce the next speaker, Professor Jinsil Seong. Professor Jinsil Seong currently is the professor of Department of Radiation Oncology in YonSei Cancer Center, YonSei University, Seoul. And he has extensive experience and achievement of radiation therapy, especially in the liver. And he is the past president of Apple Meeting 2019, where we meet and so. And he's not talking about the radiation therapy role in cholangiocarcinoma. Professor Seong, please.
Thank you, Dr. Lee. It is my honor and pleasure to join this very specific meeting discussing cholangiocarcinoma with the world experts in this field. So it's my first attendance of this meeting. So my talk is about the role of radiotherapy in cholangiocarcinoma. So when the speaker is requested for this kind of a topic, then it means that still the treatment is not well understood, well recognized by that society. And I try to share all the data with you. And I'll try to convince you how radiotherapy is a good, the effective treatment in this the disease. So let me begin with the scope of cholangiocarcinoma. Well, although they share all the same histology, cholangiocarcinoma, depending on the location, it's quite different, natural history, quite different therapeutic approach, particularly for local treatment like radiotherapy. So in this presentation, I'm going to focus on intrahepatic cholangiocarcinoma. So outline first question is that where are we? So to ask this question, we need to look at where are we in terms of guidelines. So this guideline came from International Liver Cancer Association in the year 2014. In this, the guideline for the undetectable disease, you can see that for local regional therapy and Jinsil chemotherapy is recommended but the star means there's still a low level of evidence. More recent one, NCCN guideline, was just this year, and they listed the several the treatment the category in the list. You can see that Jinsil chemo and clinical trial, 5F-based or other gene-based chemo, or EBRT, external radiotherapy, with the concurrent 5FU, and then just local regional therapy, including RT or arterially directed therapies, and also immunotherapy. This is a brief summary of the current treatment style. You can see that now the patients are treated in a various mode, including radiotherapy, not one treatment, but many treatments like resection or other treatments. So most patients are referred to radiotherapy not as a naive patients, but as a kind of a salvage aim. And also survival reaches SI as low as 40% and as high as 90%. So next, we move to a role of the role as a definitive aim. People think that the cholangiocarcinoma is kind of radio-resistant tumor. I don't think it's true. So we frequently see this tumor respond to the radiotherapy quite substantially. So this gentleman has a tumor with a lymph node mets and also high level of tumor marker, higher than 2,000. You can see the tumor, huge tumor in here. And after chemo radiation, you can see the tumor shrunken, and also the surrounding area changes because of radiation, very temporary change. So you see the tumor shrunken. Also, you see the tumor marker from higher than 2,000 to less than almost 270. So radiation, the cholangiocarcinoma respond to radiation. In another situation, you can see that although tumor here and also the matching area shown as a high metabolic uptake in PET scan, also lymph node enlargement. Now after treatment, you can see that tumors still are the very similar size. So if we just compare CT scan, just for the tumor size, people consider that this is not very responsive status. But if you look at the PET scan, you see that tumor metabolic uptake just almost normalized, not only in the primary tumor, but also in the lymph nodes. Also, tumor marker, CA19-9 from 700 to 65, almost more than 1/10 level decrease. So I want to say that radiation therapy is quite a good treatment for definitive aim for locally advanced disease. However, still, in real world, the first treatment option is usually considered as a combination chemotherapy. So one of a Korean institute, they compared Zeloda and the platinum-based chemotherapy alone versus XP CCRT group together. As you can see in this, the figures, not only in this progression-free survival, but also in overall survival, you can see that concurrent chemo radiation group shows much better clinical outcome. So this notion has been further verified through the larger scale study of using NCDB study in the United States. They analyzed their data about more than 1,600 patients and then compared combination modality with the chemoradiation versus chemotherapy alone. You can see that combination modality treatment showed much better clinical outcome in terms of overall survival comparing to chemo alone. So now recently there's a very important study came out from Taiwan group. So they analyzed national cohort, and the final cohort size was 844 patients by propensity matching, which was well distributed for 4 groups, including CCRT and the chemo alone, and the chemo followed by radiotherapy and no treatment. As you can see here in overall survival, CCRT group shows significantly higher outcome compared to other 3 groups. Particularly if we compare CCRT versus chemo alone, CCRT shows clearly better outcome. So to summarize for this part, for definitive aim treatment, RT really works in the form of chemoradiation, CCRT. And let's move to the role as a neoadjuvant aim. Now this patient present a huge tumor here, and also lymph node enlargement, and this tumor also show metabolically high uptake in PET scan. And we treated this patient with the CCRT, 60 gray high dose, and the intraarterial 5-FU. After treatment, you can see that the lymph nodes just complete regression, and tumor slight shrunken. And also in the PET scan, you can see that metabolic uptake just almost normalized. So this triggered our surgeons to decide the resection. So in this patient, with surgeon underwent resection, a lobectomy, and you can see that in right lobectomy of liver, we found out that 100% necrosis, and in operation field, the surgeon found 1 settled nodule, 1 centimeter diameter, also 60% necrosis, and all the lymph nodes were negative. So these patients clearly show that from the clinical stage T1 and 1, downstaged and downsized to T1 and 0. So clearly, this is one example showing that CCRT can do a role as a neoadjuvant aim. Unfortunately, this issue hasn't been reported a lot, only limited paper. So I'm going to show you my own group data. So we analyzed a total of 120 patients, and among them, 56 they were resectable from the beginning. So they underwent curative resection. And the remaining 64 patients, they were treated for CCRT for unresectable locally advanced disease. Then among those patients, 8 patients, which is 12%, converted to surgical status. So in these patients, we did R0 resection. Now if you look at oncology outcome, well, of course, the surgically resected patients do better comparing to CCRT because they have a favorable patients. Now you can see that initially unresectable, but after CCRT, converted to resectable and resection done, those patients' survival outcome shows a very similarly compatible outcome comparing to surgery, initial surgery patient. So it was shown not only in local regional failure-free survival, but also in overall survival. So we further analyzed the factors predicting conversion to curative resection. We found out 2 factors. First, treatment group. We compared no gemcitabine and low-dose radiation, and gemcitabine or high-dose radiation, and gemcitabine and high-dose radiation. So this more intensive treatment produced more favorably converted to curative resection. Another factor we found was there is a biological response in terms of decrement of CA99, more than 70% from the pre-treatment value. So when we see a CA99 level decrement higher than 70%, those patients from 13 to 4. So 1/3 of patients showed converted to resection. So we further analyzed the subgroup by the treatment contents. So for the treatment mode, the 3 groups are defined: no gemcitabine and low-dose radiation, and then gemcitabine or high-dose radiation, and gemcitabine and high-dose radiation. So you can see that those 3 groups, radiology response are very similar. However, if you take a look at biological response, now you can see that only 20% response in these 2 groups, but in the gemcitabine and high-dose radiation group show almost 86% biological response. And I already show you that this biological response is a very important factor converting to surgical resectable status. So to summarize this part, the neoadjuvant aim, as a neoadjuvant aim, ART is very useful modality, particularly if we consider the gemcitabine and high-dose radiation, and if we induce biological response. So there are still hurdles to overcome. First, escalation of RT dose. Previous speaker nicely summarized their data from MD Anderson, showing different treatment outcome by the treatment error. So now let's take a look at more closely. So in surgical resection group, in surgery series, the recently treated patients do better than the past group. But similarly, in radiation group, recently treated group in the year 2007 to 2015 do better comparing to the other counterpart, the past treatment groups. They analyzed the reason for this difference was due to technological development, which can deliver high dose radiation to the tumor. So in the past, we used 2-dimensional radiotherapy. At the time, we didn't get any information for the anatomical, the precise knowledge about the inside, just used the anterior, posterior field. Then using 3-dimensional conformal radiotherapy, now we know the CT scan-based, CT-based planning, use more number of beams comparing to the past. And then now we use IMRT, SBRT, 4-dimensional RT using the respiration gating, respiration control, and the charged particle treatment. In this technology, comparing to the past, only you use several beams, but now we use hundreds beam, 200, 300 beamlets are used for each treatment, and each treatment we use radiation as an image-guided technology. Consequently, you can see that tumors are very well covered by radiation field so that we can avoid other normal tissue radiation injury. So in other words, you can deliver higher dose of radiation very safely using this technology. So in the past, we delivered just the very conventional dose using conventional RT technique, like 45 gray something, but now using IMRT, for the gross tumor volume, we can deliver almost 100 gray. Now we can, using simultaneous in-field boost technique, SIB technology. So this is the real data that I use in my clinic. So this data came from MD Anderson again, and then they calculate radiation dose schedule to equally comparably as a BED, biologically equivalent dose. And when they compare the high dose group and low dose group, you can see that BED high dose group show better outcome comparing to BED low dose group, not only in local control, but also in overall survival. So this is a clinical results by high-dose radiotherapy using IMRT, proton, SBRT, and then you can see that 1 year local control, almost 90% or something, and 1 year overall survival, more than 60 or 80%. A very good result. So next hurdle to overcome is a novel combination strategy. Now, I already told you that radiation alone is not enough. We need some combination strategy, CCRT, but now we are living in the immuno-oncology era. So all the previous speakers interested nicely how immune checkpoint inhibitor works better in the cancer treatment, but unfortunately in the cholangiocarcinoma, immune checkpoint inhibitor, the response rate is not very satisfactory at the moment. So I'm going to introduce how RT is working as a good immune enhancer. So in this paper, you can see that in untreated status, very silent, so only limited or tolerogenic antigen presentation occurs in T cell and the lymph nodes. However, with radiation kills tumor cells, and dying tumor cell release a huge amount of antigen. So this released antigen trigger dendritic cell mature and increased antigen presentation. And these mature DC come into the lymph nodes and interact with the T cells, and antigen-specific T cell activation and proliferation can occur. Moreover, while anti-PD-L1 antibody treatment alone produce very limited response, with radiation, not only the anti-tumor effect of radiation alone, but also radiation can trigger tumor cells so that increased expression of PD-L1 and the neoantigen and the fast and MHC, so that more effectively T cell kill our tumor cells by combining radiation and immune checkpoint inhibitor together. So my lab tested radiation plus immune checkpoint inhibitor using the mouse hepatocellular carcinoma model. I didn't do the experiment for cholangiocarcinoma yet, but I think the same finding can be extrapolated to the cholangiocarcinoma. So in this report, we found that so radiation 10 gray increased PD-L1 in murine liver cancer, verified not only in this FACT scan, time-dependent increase of PD-L1 and Western blotting and immunohistochemical stain. And then CD8 positive T cells are key cells in immuno-oncology, and when radiation plus anti-PD-L1 combination is given, comparing to the either treatment alone, the total number of CD8 positive T cell increase, and also subset of T cells like interferon gamma positive subset and the CD107 alpha positive subset, in other words, degranulation subset, and the Ki67 positive subset all increase significantly in this combination strategy. And consequently, tumor growth decreased significantly and the overall survival increased significantly. So we further tested serum PD-L1 level change in our hepatocellular carcinoma patients after radiotherapy. In all the patients, we observed elevation of serum PD-L1 level. Importantly, if we compare SBRT group and the non-SBRT group, conventional treatment group, in SBRT group, we can see the more continuous increase of the serum PD-L1. So it can be used in the future, the combination strategy when we combine immune checkpoint inhibitors such as PD-L1 inhibitor together. Maybe we can adopt this radiation technology rather than conventional, but SBR technology can be useful. So here's the take-home message. The role of radiotherapy in cholangiocarcinoma can be summarized as a definitive treatment in the form of a CCRT, and the second one, neoadjuvant treatment converting to resectable status, and can be further enhanced by high-dose precision RT, and also novel combination strategy using immune checkpoint inhibitor. Okay, thank you for your kind attention.